Good afternoon, everyone, and welcome to today's UCSF Anti-Racism Town Hall focused on the health system. I'm Barbara Sanchez from the Office of Diversity and Outreach. Thank you all for joining us. Before we begin, just a quick note about the Q&A. We will be dedicating half of today's session to questions and answers. And while we know that the topics we cover are of high importance and we appreciate your passionate engagement, please refrain from spamming the Q&A panel. We will try to answer as many questions as we can get through in the time allotted. And also please remember that insults and personal comments are not helpful and not in the spirit of our Pride values. Thank you all. Now let's hear from Vice Chancellor Navarro.
Thank you, Barbara. Good afternoon, and welcome to our fourth in our series of anti-racism town halls. Through this series, we aim to provide transparency and timely updates to all of you about our collective efforts to dismantle systemic racism at UCSF and beyond. First, I want to say, first and foremost, that UCSF stands firmly against the discrimination, the hate, and the violence directed at Asian individuals, and the community collectively. Together, we want to see the Stop the Hate move forward, and we want to build a collective future in which all of us can thrive, have equality, equity, and belonging. Today's webinar will focus on the UCSF Health system, and following some framing remarks, we will hear from health system leaders about our commitment, our strategic approaches, and some of the ongoing initiatives. So to start our discussion, I wanted to just remind everyone of the specific elements of our anti-racism initiative. There are 6 goals that we've outlined to date, starting with creating an environment for everyone, our patients, our learners, our faculty, and our staff, an environment that is healthy, welcoming, and safe for all. We want to eliminate knowledge gaps in anti-racism so that we have an established floor to facilitate communication and engagement around these difficult issues. We want to further our commitment to the Bay Area and what we're doing as an anchor institution. And we want to make sure that, in fact, equity is essentially embedded in all of the systems in the ways in which we think and approach problem solving at UCSF. Of course, equity in patient care is critical to this work, and achieving demographic diversity throughout, but especially with a focus on how we're diversifying our leadership. And there are a number of objectives related to those collective goals. Just a snapshot here of what our workforce looks like within the UCSF Health. And here, the staff of the frontline are the majority of the overall workforce. And you can see that we are quite diverse, 41% Asian, 33% white, 14% Hispanic Latinx, and 9% Black African American, with smaller numbers of American Indians, Alaska Natives, as well as Native Hawaiians. And the diversity you can see kind of throughout. Of note is that the likelihood of advancing into a higher leadership position if you're white goes from 33% to a high of 75%. For other ethnic groups, minority groups, the numbers are essentially diminishing as you achieve higher levels of leadership within our organization. But there has been progress made. Just a quick snapshot to see that by gender, we have a majority female organization at our staff and frontline, and we moved to about 41% in the senior manager and unclassified senior manager and SMG ranks for UCSF. So one of the most important things that we can do that, in addition to the demographic diversity, is to establish an anti-racism framework so that we have the capacity as an organization to engage in these difficult conversations. And so we rolled out the mandatory training on January the 25th, Foundations of Diversity, Equity, Inclusion, that was really created and curated by a UCSF specific task force, and that has been well received by the campus community. As of March the 22nd, about 46%, almost half, have completed. I'm happy to see that health is leading the way, as they do in so many ways. 66% have completed the training on the health side. If we look at Children's Benioff West Bay, 65%, East Bay, 42%. So we're sending out reminders to everyone to complete this important foundational training for all members of our campus community, and it'll be required for new incoming students and trainees, faculty, and staff alike. In addition, some of the other climate-related initiatives that are being done to both give visibility and support to individuals has been the Benioff Children's Hospital has created a Oakland chapter of our UCSF Black Caucus. As you may know, the UCSF Black Caucus has been in existence since 1968, and Dr. Lamisha Hill is chair of the Black Caucus, but the Oakland chapter has identified the fact that one of the ways in which to support community is by creating a portrait project. And here they have individuals that have been nominated, and their portraits are available and shared so that they see themselves and then others see them as well. And these are beautiful displays of the CS portrait process. And you can ask more about that from Marsha Treadwell and others. Dr. Treadwell has been really instrumental in moving forward with the diversity, equity, and inclusion initiatives in the Children's Hospital. I also want to take this time to welcome formally a new member of the sort of champions of diversity. Dr. Maja Jackson-Trish will be serving as our executive advisor for diversity, equity, and inclusion, assistant vice chancellor in the health system. So she'll be able to extend the work reach and the depth of work being done in the health system, working both with Sheila Antrim and with me. So we're very excited to have her skills and expertise in helping to move many of these initiatives forward at UCSF. So with that, those brief remarks, I will stop and ask that Juan Ha, who is the Vice Chancellor of Communications, share a few words with all of you. Juan?
Thank you, Renee, and thank you very much for inviting me to comment on the terrible resurgence we've seen in terms of hate aimed at people of Asian and Pacific Islander descent. We've all seen this in the media. The racism directed at the AAPI community has reached tragic proportions. In the Bay Area alone, but also in states like New York and elsewhere, we're learning of attacks that are targeting senior citizens of Asian and Pacific Islander descent, leading to injury and in some cases even death. That this is happening to some of the most vulnerable in our society is as mind-boggling as it is infuriating. And of course, just over a week ago, we saw that a gunman murdered 8 people, including 6 women of Asian descent in their workplace. This is as shocking as it is for some, but maybe as predictable for others who have lived with that kind of ambient level of racism in their daily lives. Many people within the Asian and Pacific Islander community know what I'm talking about. Now, I realize that there are discussions about the motivations behind these attacks. I know that there's a key question that keeps coming up. Were these actually motivated by racism? I would say that whatever the motivations for these attacks may have been, they are happening at a time of a sudden increase in reported incidents involving anti-Asian hate. The Anti-Defamation League actually recorded some data from last year to this year that there has been a 55% increase in sexual harassment, stalking, physical threats, and other incidents targeting people of Asian and Pacific Islander backgrounds. The advocacy organization called Stop AAPI Hate has recorded nearly 4,000 such incidents just during the pandemic alone. Now, while these numbers are shocking, there is a lineage, I would say, that connects the incidents that we're seeing to key moments in our history. You've all read this online. The Chinese Exclusion Act of 1882, the internment of Japanese Americans during World War II, the xenophobia that we saw during the Vietnam War and the backlash seen against Asians during the rise of Japanese economic power in the 1980s. But the truth is, anti-Asian and Pacific Islander racism, just as with racism experienced by our Black, Latinx, and Native American families, friends, and colleagues, is part of the fabric of bias and discrimination that is woven into our societal structures. While the experience of racism is unique, and we should not try to compare the experience of one group with another, there is a common undercurrent, and that is systemic racism. As people of Asian and Pacific Islander descent know, they live with this persistent ambient level of anti-Asian racism, and it spikes every now and then. The complexity for many Asians is that this issue is tied up with issues related to immigration and foreignness. It's a unique combination of factors that result in a specific form of xenophobia. But what we're witnessing now, and I think because it is getting such attention from not only the spectacular aspects of the attacks that we are seeing, but because many more people are stepping up and voicing their protest. What we're seeing now is an opportunity. We are seeing an opportunity to reveal and make visible what many people cannot see. At UCSF, I'm proud to be part of an organization that includes groups like APASA, the Asian Pacific System-Wide Alliance, and AAPI, the Asian Health Institute. APASA has been providing support to the AAPI community and its allies during this very difficult time. They've been creating virtual healing spaces that people can connect, share, and process what they are witnessing and living out. They also have a number of events coming up in May, which is Asian American Heritage Month, and I encourage you to connect with APASA to see if you'd like to learn more about their activities and the support services that they're providing. The Asian Health Institute has for years been working to address health and health inequity as a part of UCSF's public mission. If you'd like to learn more about AHI, I encourage you to contact Diana Lau, who's been doing some fantastic work leading these efforts. Now, in closing, I want to express my appreciation for Chancellor Hoggood and Mark Larrett. Their leadership and their ongoing commitment to the broad range of DEI activities across UCSF is more important than ever. And a special thanks to Vice Chancellor Renee Navarro. The work that she and her team are doing to lead us through the anti-racism initiative work is just incredible. The range of work that she and her team are organizing in such a short amount of time is breathtaking. And thank you for joining the town hall today. I'm looking forward to yet another great discussion.
Thank you very much, Juan. We very, very much appreciate your words. And now we have our leader, Mark Larrett, CEO and President of UCSF Health. Mark?
Thank you, Renee, and thanks everyone for joining today for such an incredibly important topic. As I was preparing to think through what we wanted to make sure and cover today, I found myself being overwhelmed with three emotions: sadness, rage, and being ashamed. The sadness from what we have seen in this past year, this past week, is overwhelming. That we still in this country see such shocking displays of racist behavior. The enragement comes from the fact that over the last several years, there has been voice given to those who harbor these attitudes in our society. It is not acceptable, and we must stand firm against them. But the part of me that's a bit ashamed is how little we have done, and maybe how much of a realization that we had to go through in this past year to realize that what we have done as an organization, even one at the forefront in human rights as UCSF is, how little we have done. I reflected back on when I first joined UCSF in the year 2000. The hospitals in San Francisco had just completed a survey of the health status of all San Franciscans by racial and ethnic groups. And the results were shocking to me, that the health status of every group was improving except one, African Americans, and it was declining in San Francisco. And I remember asking a good friend of mine, Tony Wagner, who ran the San Francisco Health Plan, an African American, why that is in a city as liberal and socially supportive as San Francisco is, how this could even exist. And he reminded me that it wasn't that long ago. It was just in the 70s that the Tuskegee Airmen experiments, where the federal government experimented on Black airmen, just ended. And he reminded me, Mark, Black people have a serious mistrust of the health system. And as we did focus groups among Black patients, we learned, in fact, it was true. Not only mistrust, but notable differences in how patients were treated, the options that they were given, the expectations that our providers even had for our patients based on race. So I am ashamed that in 2021, we have not come further. Now, let me just mention two areas that I think are the central focus of our work. Number one, which I would argue is the single biggest issue in American healthcare, is health inequity based on race. We could talk about health inequity based on a whole host of other issues, but health inequities stands as number one. We're going to hear more about that today. But UCSF is taking a number of steps to start to address this issue, even finally starting to measure how different racial groups that we care for, how they're performing, how they're doing in areas like hypertension control or diabetes management or other areas. And sure enough, we're finding disparities, not in every area, but in many areas that we need to focus our attention on. But the second area is also important, and that is racial issues inside our organization. Renee highlighted the composition of our management team and how we are still predominantly white at the top and more African American, Latinx, Asian at the bottom of the organization. I just want to let all of you know that we have undertaken a series of initiatives inside the health system, over 30, to address a host of these issues. Among them, reinforcing the point that Renee made, that everyone needs to take the Foundations of Diversity, Equity, and Inclusion training program. Everyone needs to be grounded in the same basis. But further, what we're trying to do at UCSF Health is to make sure that when we're recruiting for any senior management position, that we have a diverse group of people on the search committee, that we must have a diverse group of candidates, and that our efforts are going to be to recruit diverse individuals to fill leadership positions. We're also quite focused on making sure that when employees are terminated from the organization, that the review of their termination is conducted by a diverse group of individuals, because one of the things we have learned in this past year is that there's a disproportionate number of people of color who get terminated involuntarily from even UCSF Health. In another 10 years, this issue must be remarkably better than it is today. And I will just say to you that my commitment over this next year is to do everything I possibly can to set in motion additional steps to ensure that UCSF is the safest, most supportive, and the most anti-racist organization in our region, in the university, and in the country. We owe ourselves and our patients and our employees nothing less. With that, thank you, and I will look forward to questions later on.
Mark, thank you very much for your leadership. I can say that 20 years ago, I was also a part of that African American Health Initiative and did those analysis, and I've been working ever since. And there's some improvement, but is, as you say, way too slow. We're fortunate to have a team who's working on these issues mightily at UCSF. And we have for you our next presenters, Drs. Malcolm John and Diane Swifka, who co-lead our Health Equity Council. Malcolm?
Thank you.
Diane?
Thank you, Mark and Renee. Can you hear me okay?
Yes.
So Dr. Malcolm John and I, as co-chairs of the Health Equity Council, will use this section to really walk you through what the focus has been of UCSF Health's Health Equity Council over the last 3 years, and also through what our disparity improvement efforts are focused on now, as well as what we are doing into the future. I want to just call out that we have a Health Equity Council leadership team that includes Kevin Grumbach, who is the chair of family medicine at UCSF, Matt Wolden, who is the VP for quality at UCSF Health, and Sarah Lahiji, who is the program manager and dedicates her time to all of this work. Malcolm, I'll turn it over to you.
Thank you, Diane, and good afternoon, everyone. I want to digress just a wee bit first. And say that I stand and act with my AAPI sisters and brothers, and I hope and believe that all of you do as well. I really appreciated the opening comments. It's been a very difficult time for many in our community, and I'm so proud to be part of this group that are working to bend that arc of justice. So with that, I'll start us off by showing this strategic framework that we've created of the various levers needed to advance healthcare equity and anti-racism work here at UCSF Health. It includes, though not necessarily limited to, the domains showed here. The Health Equity Council itself focuses mainly on the quality aspects outlined in red in the first row. We know it is our role to work and partner across these other domains and do so, in part as many of our members are key leaders in these other areas. Next slide. The council itself was activated by the School of Medicine Differences Matter Clinical Health Equity Action Group. Alicia Fernandez, Michelle Johnson, Noelle Lee, Natalie Purcell, and myself, as through our work, it became clear that discussions about how to view and implement healthcare efforts with an equity lens were inconsistently being held, occurring in population health and other groups, and we needed a body to sustain, prioritize, and align the conversation work more broadly to have more meaningful, long-lasting impact. We reached out to then VP of Quality, Niraj Sehgal, and VP of Population Health, Kevin Grumbach, to be co-chairs, and they ran with it and really developed it and made it a reality with the purpose and scope that are outlined here. I'll emphasize that our membership includes diverse health systems, operational and functional area leads, health disparities experts, and Dean's diversity leaders. I underscore the operational and functional leads, as the council itself is not an operational entity except for a few targeted pilots, but rather our members are operational leaders that bring to us issues or natural leads for our initiatives. Next slide. So some highlights. Under culture and awareness, as you can see in our top section, we've shared health equity vision with key leadership in the broader community through our improvement leadership retreat and poster symposium and our first equity report, and more recently, a health equity inventory. As for data and analytics, I want to highlight that this is a key foundational work that has been done through our health equity task force, which we started at the beginning of the council. With population health, it has developed the new race and detailed ethnicity categories and a new schema for applying a UCSF-derived race ethnicity variable for routine equity analyses. And we hope and encourage all of you to use that moving forward. We are also advocating strongly for the same for SOGI, sexual orientation and gender identity. And lastly, for disparities improvement, I'll emphasize that we have highlighted health equity metrics at the enterprise True North scorecard level. I hope many of you are familiar with that, and have expanded from 1 to 5 disparities improvement efforts and established 2 new key committees that are listed here to support this work. More on that later. Next slide. Looking forward towards culture and awareness for FY21 and beyond, we are focused on improving and engaging our community to get more involved with UCSF Health's equity work through town halls, an upcoming pledge campaign, and other efforts to come. Also, we're hoping to connect more with campus-led efforts, such as our health equity inventory. There's a QR code on the screen here that you can use to see the over 100 submissions and initial analyses. We've realized so much is going on that there is a need to foster better alignment, efficiencies, and innovation, understanding that we did not capture things like the important grassroots activities that are occurring all over the campus, and we hope to capture that in future inventories. Next slide. Finally, with regards to disparity reduction efforts and analytics moving forward, we hope to continue prioritizing healthcare sensitive disparities that are most critical for disparities reduction and highlighting those on our True North scorecards. Importantly, we will support our disparities improvement task force to support teams doing this work, to develop best practices that can be disseminated across the enterprise, and to develop recommendation for UCSF Health's approach to social determinants of health through our social determinants task force. In the middle here, you'll see that we aim to establish and promote consistent system-wide data definitions and governance for equity-related predictive variables, SOGI, language, payer mix, et cetera. And finally, to integrate health equity into the QI infrastructure, reporting up to the Quality Improvement Executive Committee, integrating within Clinical Performance Improvement Committee so that equity is part of the clinical unit's work and really permeates throughout our departments, and ultimately to facilitate the application of quality improvement science to disparities work, learning from the transformative journey that UC went through with respect to QI culture or quality improvement culture over the last decade or so. And this includes enhancing our community's ability to do this work through consultations, toolkits, integration into dashboards, and other strategic efforts. Back to you, Diane.
Thank you, Malcolm. So we know that so many of you are doing anti-racism work, disparity improvement work in your local areas. We also know that as a health system, we want to be accountable to these improvements, and we need to be looking at this as a system. And to that end, what we see here is the True North dashboard and scorecard, where we have this year expanded to looking at 5 improvement areas where we see disparities across race, ethnicity, and language, and across the health system, both in inpatient and outpatient areas. And this is, again, an expansion of areas of focus for the system in the True North dashboard from the prior year, where we were really looking at hypertension as a focus. Use the COVID example to tell the story of how we apply quality improvement principles to this improvement work. But COVID isn't the only place where we see that our structures and systems may be enabling disparities for our patients. And so as we look at this example, thinking about how we learn from this in ways that we can apply this across clinical disparities. So in the PDSA cycle you see here, which is to plan, do, study, and act, what we start with is data. And in combination with our clinical systems and health informatics partners, we were able early on in the pandemic to really identify where we had disparities in our own patient populations. And the orange and red bars show you that in our Latinx patient population, we had a striking increase in case positivity and in hospitalization rates for COVID compared to their representation in our patient populations. Knowing that information allowed us to say, this is the area we are going to focus on right now, create hypotheses about why that might be and what might be the areas that a health system could intervene on that would improve those outcomes. And then start to implement resources and teams and reorient existing teams to focus on how we can implement interventions. And so in the bottom left, you see a host of interventions that were tried initially with the hypothesis that if we could test this group of patients earlier, we may be able to prevent the spread of COVID-19 sooner and improve on these outcomes. And that outreach to this group in order to improve testing and early testing was done not only through our digital methods that were easy to do, like MyChart, but also working on snail mail, postcards to talk about the dangers of COVID and to encourage people to get tested if they wanted to. And then also focusing in on phone calls, so we were reaching patients better. And then looking at language. So prior to looking at this work, what we knew was that most of our outgoing communications were in English. even though our patients' primary languages are not all in English. So making sure our email messages were in Spanish, our paper messages were in Spanish, that our website that our patients were being asked to look at for COVID was translated into Spanish. And then as we move forward into vaccine rollout in December and January, taking the groups that had been put in place to start looking at these efforts and applying them to the vaccination rollout in the same way, applying the same principles. And that COVID equity work group and population health partners have just been amazing at stepping in to do this work. And lastly, looking at our data. So how did we do? Did any of these interventions make a difference? Were there any unintended consequences that we should be responding to adjust? And what's nice to see is that at these time points 1, 2, and 3, where these early interventions were put in place, the black line that shows our UCSF Latinx population shows a statistically significant drop off in case positivity for COVID, where we didn't see the same for our SFDPH Latinx population or for our UCSF or SFDPH white populations down in gray and orange here. We also know that hospitalizations improved in this time period for this patient group as well. And although we can't conclusively say that it was these interventions that made a difference, this is information that we will continue looking at and responding to as we modify our interventions. I want to close with just our future directions, focusing in on 2 of them. One is really to continue to double down on language access. Spanish isn't the only language that our patients speak. We have a lot more to do to be able to address patients in the language that they speak, both when they access our care and when we reach out to them. And making sure that the digital divide that has really been pronounced with the growth of remote visits doesn't continue to increase disparities, but rather that we have interventions that improve care for all of our populations. The second I want to emphasize is patient voice and making sure that we are not implementing interventions we think are helpful for these populations, but rather that we are listening to our patients and families in our communities to meet them where they need us to meet them and giving them what they need from us. I want to say thank you to everyone who serves on the Health Equity Council. This is an amazing group of experts and leaders in the organization, and also to recognize that no one council, no one person can do this work. Here we've tried to name a lot of the groups that have been instrumental in making all this work happen. And we want to continue to partner with all of these groups as well as with our frontline employees and clinicians and trainees and students as we move forward to do this work.
Thank you, Dr. Swifka and Dr. John. That work is so illustrative of the collective efforts that are necessary to truly move our campus and our health system forward to where we need to be. Another key element of our anti-racism initiative is to create a safe and healthy, welcoming climate for all. And in light of this goal, we took a holistic approach to looking at safety and security on our campus. A task force with membership from across the campus and UCSF Health was co-chaired by EVC Dan Lowenstein and me. This group worked really diligently to meet the needs of our campus community and our patient population. Within that, we identified the need for an appropriate response to instances of disrupted care that we could bring to bear appropriately aligned resources, and that security was not always necessary in those instances. It is with that in that light that it's my pleasure to introduce Jamie Phillips. Jamie is the Vice President and COO of Benioff Children's Hospital, and she's here to describe a new program, the UCSF Health Care Team for De-escalation events. Jamie?
Hello, everyone. Let me get my PowerPoint up there. All right, so I'm going to give an update. We actually have a new name for this group. It's called the Care Support Team, and give you an update on the progress that has been made to date. Just as Renee was alluding to, there are some real facts of why we needed to develop this team. We have and still have situations within our organization where there are room searches that are really being activated without complete rationale and not aligning with our policy. In addition, we have activated prematurely our security, particularly around caring for people of color. And this is really sometimes happening without really related to due cause or and how to actually resolve it appropriately from staff end, but also as well as from patients and families. So our acronym for this team, which there is another CARES team of support for staff, but this is particularly related to the team of de-escalation. The acronym means C, consider the facts. A, be awareness of our assumptions. R is recognizing the multiple perspectives of the situation and the individuals. And then lastly, E is evaluating the best options to move forward. So as we go through this, this will be embedded in how we approach training, how do we support a situation, and our new program manager, she came in and right away came up with an acronym that we could use for this group. As a refresher on the goals, there are 3 elements of it. One is the anti-racism. As you heard, one of the things we need to do is eliminate racial ethical disparity in the use of security and police within our health system. Another one is how do we increase our staff's tolerance to a normal range of emotional response and not jumping, as I mentioned prematurely, to our police and security. In the element of patient satisfaction, we need to make sure that the patient's voice is being heard and understood. And how do we—
Sorry, let me just put this on mute for a sec. Hey, so this is—
Hello? Oh, okay, sorry about that. And how do we are preparing for our families to make sure that they are part of the solution as we go through and handle de-escalation activity. And then the last piece is making sure we have the appropriate support and training. And that means the right team that can handle these, but also the training around anti-racism, around crisis prevention and intervention, and around trauma-informed. As Renee alluded to, this is the structure of how we have approached this pilot. There is a recommending body that you'll see on the next slide that is comprehensive of various different stakeholders within our organization. And that recommending body has really put a ton of emphasis on, operationally how this is going to work, the training. It's not a one and done, but what we're going to do ongoing in the years to come. And then also a particular curriculum and effort around anti-racism. So to the point I mentioned before, this is definitely is a multidisciplinary group of individuals from UCSF, from BCH, from campus, I would even add that. And it will be ongoing, and there's names behind each one of these bubbles. So it has been a very comprehensive approach to make sure that we're looking at it at very different lenses. At a high level with the CARE team, just to keep in mind, it is a 24/7 team that is established. For that, there will be management oversight of the team, and that their real objective within the pilot that we're starting with to make sure as we roll it out is completely in alignment to our goals. We're going to start at Mission Bay on a couple units, as well as in our ED in public area spaces. The team will be structured like similar codes teams that we have, for example, Code Blue. And to the right, you can see the various composition of members there. As I mentioned before, one of our main objectives is to reduce the amount of need for security and for police. But knowing that if we need to go to that level, we will. But as you look through here, there's 4 different levels going from the bottom up that initially we want to have our program manager work very closely with the units. Jonique Bell has started already. She rounds daily on the units to be proactive and understand if there is any interventions that she needs to get involved with, or with any of the team members as part of the care support team. As you move up, you can see we really do not involve security until we get to level 3. And that will be, again, as things escalate and meeting to policies, we will appropriately include our security employees, but that should not be our first level response of what we're trying to establish with the team that we have for the de-escalation events. So in summary, what we have done to date over the last 6 months is established our team. As I mentioned, Jonique Bell, she's coming from our labor and delivery department at Mission Bay. She started in March, and she is actively already making leeway and progress of where we want to go with our program here. We have hired 24/7 social workers, and they are getting onboarded. On the infrastructure, we have how to activate this team. It's already being currently activated very often. And then also, how do we document appropriately in APEX and how we are conducting daily huddles with our units. In the training, there's been extensive training that has been established around crisis prevention and intervention, around trauma-informed training. We're also collaborating with Glide to give another perspective of training to our team. And in addition, we will be doing mock drills, role playing. And this, as I mentioned, it's not a one and done training. What we're learning with this training is that we need to refine it to where we are in today's society. Some of this training is not to that level of what we would expect. So please know that it's evolving. Lastly, as I mentioned, we are starting Mission Bay. It's active, started last week. Parnassus will start in April. Oakland will start in June, and Mount Zion in fall. Thank you.
Thank you, Lisa. Cisneros will lead us through our question and answer time period.
Thanks, Renee. So we have quite a number of questions. Thanks for those of you sending them in. Let's go first to Renee. The decreased diversity of our campus staff leadership has been reported yearly. What's been the change in diversity and gender of management and leadership among our staff?
Well, there has been growth in the diversification of leadership in the staff level. In particular, if you look at the executive leadership, the Chancellor's Leadership Council, we have undertaken steps that implement best practices in the search process to assure that we are identifying a diverse pool of candidates for all leadership searches that have happened. And we have our data over time in which we have seen an increase in the diversification of our staff and leadership roles. But it'll be an ongoing effort to continue to do so. And we've established as standard practices in all of those searches that we will be implementing these best procedures requiring contributions to diversity statements, the diversification of our search committee, training on the impact of unconscious bias in that process as well. So those are among the strategies that we've put in place to assure that we continue to identify outstanding diverse candidates for these roles.
Great, thank you so much. This is for Mark or UCSF Health Leadership. Do we currently systematically screen patients of color if they have experienced discrimination or mistreatment while they are receiving health care, or do we only track this when they report a grievance?
Well, I will start. Sheila may want to add, or maybe Jamie wants to add. But part of the reason that we want to really focus on this foundations training program so that everyone's awareness of this issue is heightened. That's been one of our problems, is that we have people who think they are carrying out their work in a great fashion, but they may be unaware of microaggressions or little things that they say that reflect an underlying unconscious bias. So where we're really starting is, rather than asking the patients, although we certainly do give patients every opportunity to express their concerns about their care, including racial bias, and we do get comments about that. Our real focus has been on making sure that we're increasing awareness of the staff who are providing care. But let me turn it to Sheila for additional comments.
Yes, I think that's right, Lisa. We have a process in place now for patients and grievances. And I think that the goal is every patient should be treated the same, but if there is an issue that comes up, it should go through the grievance process, and then it is feedback in that regard. So I think that the answer is that we follow our processes, but then again, with this heightened training and all of the support we're putting in now, there should be less of that going forward.
Great, thank you. I think this question is also for you, Sheila. What is being done about the continued racism and microaggressions being experienced by nurses of color?
Yeah, this is an important one, and I think that it has come to my attention directly. I think a couple of things. One is immediate support for the people that are experiencing these microaggressions, and so I have reached out and actually have gotten support from others to be able to handle how these questions come up and why. Second, I think that with some of the training that's happening today, but also with some coaching and counseling that Dr. Jackson Trish will provide, I think there's another element of heightened sensitivity around some of these questions that continue to come to our staff.
Okay, great, thank you. This question is about the composition of the Health Equity Council that can either be answered by Malcolm or Diane or both. So how are individuals selected to be part of the council, and does this council include nursing leaders?
Thank you for the question. And in terms of the first part, I think I answered in the chat, but basically, when we put forth the proposal for the council, we requested that it included operational and functional leaders so that it's not just a lot of talk, but actually the people who make the decision and influence the implementation of systems change be at the table. And so that was what was approved by the health leadership at UCSF Health, and that was the intentionality. People were chosen to essentially cover the domains that were outlined in slide 2. We weren't, although I have to say, Diane and I weren't involved in the final selection process. That was sort of the driving impetus. We anticipate, clearly the committee has evolved in terms of its scope and activity, and we anticipate revisiting enrollment or membership for FY22. So for those who are interested, TBD, and excited that that question is out there. It seems that people are interested. And then I can't remember the other part of the question. I'm sorry.
That's okay. There was also a related question about the racial, ethnicity, and demographic composition of the council.
Yeah, I'll have to get back with the details. I don't want to self-identify some of the members, but there is a range both by gender and ethnicity and sexual orientation. But that is a great question. We don't yet have a website, and I hope we can get that up there for people. I do remember the other ones about nursing representation. We do have folks like Kate Burke and others with nursing background. Again, we can be more explicit about that membership moving forward.
Great, thank you for that.
Mm-hmm.
This one is for Mark. What are we doing to hold our affiliated hospitals and clinics to have these standards of DEI and to make sure our patients everywhere are being protected?
Yeah, it's a great question because as we've been expanding our network over the last several years, we've learned a lot about how they operate and how they're different than us and how they're like us, and in some ways how they're better than UCSF in some ways that they operate. But I will say, as a general rule, that we put a lot more attention on these issues than any others do. And to the point of this question, which is a really good one, we have begun to ask our affiliates to start to abide by many of the principles that we have. For example, one that's very important and has been an issue as it's related to our partnerships with Catholic healthcare institutions is participation in the Health Equality Index that is a metric of how welcoming an organization is for gay LGBTQ plus individuals, patients, and staff. And one of the things I'm very pleased about is that in California, Dignity has made the commitment that in Northern California to start with, and I assume over time across their network, that they are becoming certified as HEI institutions. A lot of credit for this goes to a dear member of our extended UCSF family, Shane Snowden, who many of you will know from years ago, worked here at UCSF, and she's been a real pioneer in this. But I think this is a great message for UCSF that as we reach out to other organizations, we bring our values to them. And I think this has a positive effect on our patients and our broader communities.
Okay, thanks, Mark. This one's for Renee. Diversity statements during hiring and promotion have been mentioned time and time again, but what is actually done with these diversity statements, and how do we ensure that these statements are tied to actions and behaviors?
Thank you. That's a wonderful question. So the diversity statements, we instruct in our conversations with the search committees to actually utilize those diversity statements as one of the first components of an analysis of a pool of candidates. So if in fact the diversity statement fails to meet, and we have a little bit of a rubric that we provide for them to use to look at the statements, if a candidate fails to meet that, then in our opinion, they don't meet minimum qualifications. And so in fact, some searches use that as one of the first tools to actually screen the pool of candidates as one of the required qualifications, and then move on to the additional analysis of candidates. The ultimate decision, obviously, for the selection of individuals is left to the person who is the hiring manager. But we then go back and look over time at the hires made by any given hiring manager to see if in fact there's a disproportionate impact relative to the diversity of the pool. We work with them through our faculty equity advisors and more recently staff equity advisors to help them identify a pool of diverse candidates that is reflective of the national or local availability pool, depending on the job. And therefore, they have all the options available, and then we do accountability for decision-making as in the rear of the hiring process.
Thank you. This one's for Sheila. Can we be more proactive to survey patients, especially those who have not filed grievances, to determine the extent to which they have experienced systemic racism in our environment?
Yeah, I think we can, and we are. So right now we are actually using patients in focus groups to really get an understanding of what happens. And those people have not always filed grievances, but actually enjoy getting care at UCSF. So I think there is a proactive measure in certain areas to combat that now.
Excellent. This one's for Mark. What % of UCSF Health's budget is reserved for health equity, diversity, equity, and inclusion initiatives, and how are these resources directly extended to departments and divisions?
Well, that's a good question because I think there's a fairly standard statement that you can judge an organization's values by where it spends its money. We think about this as less about a budget issue than more about a management expectation issue. So we don't have to allocate additional dollars to search teams to require that the search teams be diverse and that they develop diverse pools of candidates. Now, if we need to do more advertising and marketing in publications that better reach diverse communities, we will absolutely make a commitment to support that. But this is, I think, an organizational effort like the CARE initiative that Jamie just talked about, where we're adding significant numbers of staff to help us have a 24/7 team to work on security and safety. So I can't actually answer the question specifically. Some of it is actual specific dollars for DEI initiatives, but more of it is in how we expect our managers and our employees to conduct themselves and providing the training, guidance, and oversight for that.
And just to add to that, I'll just say that the Office of Diversity and Outreach is an enterprise-wide office, and the health system supports the funding for that office. The LGBT Resource Center, the Multicultural Resource Center, our confidential care advocate for those experiencing sexual harassment. Those are all campus and health system-wide resources that are supported by and available to everyone, as is the Office for the Prevention of Harassment and Discrimination and the Center for Educational Outreach. So we are part of the same team.
Great. And I'll stick with you, Renee, for this question. Is there any conversation around providing compensation for those in our organization that are volunteering their time and talent to DEI efforts across UCSF?
There's certainly, thank you for that question, because there certainly have been a number of questions about that. For the faculty, there are expectations that our faculty engage in community service. Many of our faculty choose to do so in areas of diversity, equity, and inclusion. Similarly, for our staff, many have participated, for example, in our staff DEI certificate program and have skills and expertise that they're expected to bring to their local divisions and departments. And there have been questions around reimbursement or time for them to do that. And I think we're still working with human resources on the best way. I mean, our goal is to embed DEI as a part of who we are as an institution. And if you're a manager, part of your skill set and your competencies are that you're expected to have a competency in diversity, equity, and inclusion. And it's not in addition to your job, it's your job. And so how do we sort of balance that? I mean, it is where we're still wrestling with that at this point.
Okay. This one's for Executive Vice Chancellor and Provost Dan Lowenstein. What concrete measures will you enact to prevent senior faculty from undermining changes in their departments in terms of behaviors of microaggressions and such?
Well, that's a deep question, because it really gets at the roots of the culture change that we've all been working on, and that you've heard the overview from Renee and the work that her team has been doing for a decade now, and in close concert with the work that we do out of the EVCP office and the Office of Academic Affairs. So we have standards that we expect our faculty to meet. We have the training that has become required, and we're doing everything we can to hold our faculty accountable for their behavior. So I think it's a general question, but I think there are many examples of the approaches that we're taking to changing the culture here at UCSF to address those sorts of behaviors.
Okay, great. This one's for Mark Larrett. The recent dropping of the Anthem medical contract for primary care services will remove low resource patients from their longstanding primary care relationships with their primary care provider, and will likely disproportionately impact patients of color. Is UCSF Health paying attention to this potential inequity in its contracts?
Oh, we certainly are. We've spent a huge amount of time on this. Unfortunately, this question highlights, and this circumstance highlights a fundamental problem in our healthcare system. So as we were renegotiating our Anthem Medi-Cal managed care contract, by the way, we're one of only 2 University of California health centers that participates in this program to make sure that we are extending our outreach to the Medi-Cal managed care population. But Anthem's proposal to us was to cut payment by 40%, a significant hit, and we said that's unacceptable. We have spent a very difficult several months negotiating the terms of this contract. And I think where we've ended up, it's not perfect, but it's not a bad place where every one of those patients has the opportunity to change health plan. And while we're precluded from encouraging them directly to do so, there are great options for them, and they can change health plan every month. And they can continue to be seen by UCSF providers, either through UCSF or through ZSFG. And in Oakland, in the Inner East Bay, we've also worked out a mechanism with the Alameda Healthcare Alliance. So we put an enormous amount of attention on minimizing disruption to all of our patients, particularly our underserved patients, in everything that we do. And while it isn't an ideal outcome, it is part of the day-to-day noise that we face in trying to manage the operation, working with health insurers, and doing what's best for our patients.
Okay, thanks for that. Well, this one's for Renee. Some departments are relying on outsourced workers to fill campus staff positions. Is this something that will be re-examined considering the issues with racial and gender representation in our workforce?
That's an excellent question, and I have to say I don't have a lot of information about that. We understand from our some of the discussions at the level of the regents about not using contract workers, and we are certainly seeking to limit the amount of outsourcing that takes place amongst our staff hires, and we'll continue to do so and look at that information critically. I mean, our goal certainly is to provide full-time UCSF jobs for individuals, and to do so in a way that doesn't disenfranchise or have a disproportionately negative impact on any group.
Okay. This one's for Chancellor Sam Hawgood. With UCSF campus providing the care to many disenfranchised populations in San Francisco, what efforts are being made by UCSF to work with the San Francisco Department of Public Health to address pay parity between UCSF campus employees and those working at Zuckerberg San Francisco General, for example?
So I'll answer that in two parts. First, our relationship in general with San Francisco Department of Public Health. I would say that it has never been stronger in its over 100-year history than it is at the present time, driven, of course, by the shared emergency of addressing the public health crisis of the pandemic over the last year. There are just so many examples of where we have worked absolutely hand in glove with SFDPH, assisting with policy recommendations, but also work on the front lines of the pandemic by providing free testing, currently right now, moving vaccines into some of the most underserved areas of the city and county. So very good relationships extending from the mayor through Grant Colfax, the director of SSDPH, and all of the staff. On the issue of pay parity, that is a more complicated and nuanced discussion in the sense that while we employ the physicians at Zuckerberg San Francisco General Hospital, the city is the employer of the nurses and almost all of the other staff. And therefore, the city is responsible for the union contracts and those negotiations. And while we can work together to try to create equity, ultimately, we are two different employers, and those contracts are negotiated separately.
Okay, thank you, Chancellor. I'll stay with you for one more question. What plans does UCSF have to increase funding for the Office of Diversity and Outreach? This is a question that's come up before on anti-racism town halls. Specifically, they're increasing their work in terms of DEI trainings, workshops, the certificate program for staff. And so what are the plans for ODO funding?
Sure. So I have specifically asked Chancellor Navarro, and she is doing a terrific job with her team to come up with a comprehensive budget for the UCSF Anti-Racism Initiative, which, while it's led out of Renee's office, touches many, many other parts of the campus. And we're headed into budget season right now, and we'll be addressing those issues over the next 1 or 2 months. In terms of the specific office to take care of the kinds of things you just described, the training work, the anti-discrimination work, the investigation work, that workload has absolutely increased, and sadly increased fairly dramatically over the last year as the spotlight has been shone on these areas. And Renee is working with me to add staff to deal with that increased workload. Obviously, I would like us to eventually get to a place where we are focused much more on prevention and restorative justice than we are on disciplinary actions. But it's a work in progress, and we will make sure the budget matches the work required.
Great. This one's for UCSF Health leadership. I'm not sure if it's Mark or Sheila. Or wondering about updating terms of and conditions of service agreements with a section on microaggression and racism. We need to openly address this and have set agreements with our patients as well. Comments on that?
Sheila, do you want to go ahead?
Yeah, that's the taco. I saw a lot of comments on that in the Q&A, and I think it is something we should take offline and have with the Health Equity Council, as well as patient relations and others, that this has to go all the way through. So it's a valid point. I think that it warrants a review.
Okay, thank you. Another question, I think also for you, Sheila, is have we considered pushing EPIC to include DEI-related reporting to address disparities in care among different ethnicities?
I know I'm really not sure I'm exactly the right person for that, but I think more importantly, Lisa, is how do we have the conversations around patients, in relationship to the care, which gets to the whole care planning that you see in the Health Equity Council. If we can actually have conversations and use the care planning and actually include DEI in that manner, everybody gets to see what's happening with this patient, which I think is probably most important.
Okay.
I'll just chip in that, in fact, we have raised the issue about simpler reporting, easier reporting of data around race and health inequities with EPIC, and I'm hopeful that this will move front and center to their radar.
Okay, this one's for Malcolm. What data points do you use to look at clinical disparities?
Before I answer that, I wanted to invite our Health Equity Program Manager Director, Sarah Lahiji, on because she's very involved in these efforts. So I'll let Sarah start first.
Great.
Thank you so much, Lisa and Malcolm, for this space. So we collect information by race and ethnicity and consistently use that in a variety of reports. We also use language, and we have ongoing efforts right now to understand financial class, which is often referred to payer, in a more standard and consistent way across the institution, as well as thinking about language fluency or literacy level. In addition, our group really advocates for the advancement of sexual orientation and gender identity work, as well as social determinants of health, thinking about things like houselessness that someone might experience and how that might impact their care access. I hope that's helpful.
Thank you.
Okay, this one's for Mark. What is being done to help create career growth opportunities internally and potentially move some of the current frontline staff of color into manager level positions?
Well, this to me is one of the most important management initiatives that we've begun. We haven't brought it far enough along. My vision, which I've talked about with my management team at some length, is that we should be an employer where someone can come in here in an unskilled position and through training move themselves to develop some skills, maybe go from a food service worker to maybe a medical assistant to an LVN to a tech. And we do have examples of people who have done it, but we have not made it easy for them. So this is one of the areas that I think we need to put our greatest effort to, because we want to make sure that this is it's part of our vision at UCSF Health, have the best environment for teaching and research, be the best place to work, and have the best quality of medical care. That best place to work is really focused on having a career ladder. So this is an effort that Corey Jackson, who's our Vice President for Human Resources and Vice Chancellor for Human Resources for the campus, has front and center on his agenda as well.
And can I just add as well, Lisa and Mark, that this is something as well, just to highlight that we are working on that, and we have an individual named Michael Jones who's joined our organization and is working on the career pathing piece that's also aligned with the work of our Anchor initiative. So it's a commitment that we have as a solid community partner in working with our community-based organizations externally and bringing in more diversity, as well as creating those same opportunities once we achieve diversity within the organization, that we can move from the entry levels all the way up through the organization. So it's work that's underway.
Thank you, Nancy.
Thanks, Nancy. To Malcolm or Diane, to what extent is our relatively new bioethics program contributing to the Health Equity Council's efforts?
I'll take that. I don't think we've had an explicit connection to the bioethics program, but I appreciate that suggestion as something that we could look at going forward.
All right. Winding down here, I think I'll just turn it over now. Did somebody want to say something? Okay. I'll turn it over now to Chancellor Sam Hoggood for closing remarks.
Thank you, Lisa. As we bring this session to a close, let me first just thank all of the panelists for what I think was some really meaty presentations of work in progress and outlining some of the areas that our focus is on and where we are making important progress. Let me also thank the more than 1,000 members of the audience. I know that every single one of you has a busy job, and it's hard necessarily to find the time to attend sessions like this. I really appreciated the quality and substance of the questions that were asked and the searching for answers that will make us all better. So I appreciate it. This is very complex work. If there were easy solutions, we would have found them, but only by engagement of the entire community in sessions like this can we as leaders move things forward. I think the two programs that we highlighted today, I would just like to make a comment about both of them, because while they may have come across as leadership initiatives, both of these really grew from the front lines up. I really credit Dean King in the School of Medicine for 5 or 6 years ago, establishing a critically important project that started in the School of Medicine called Differences Matter, but it became clear that there needed to be a clinical focus, a patient-facing focus of that initiative. And that's where the Health Equity Council was born now almost 4 or 5 years ago, and it's come a long way. Patients' voices are heard in that council, and I think, as was evident, if we are truly going to live up to advancing healthcare worldwide, then we need to hold equity of the care that we provide front and center. The other initiative that COO Phillips described, that is the CARES program, really arose from advocacy from our residents across the health system, watching and seeing difficulties in terms of events escalating beyond where they needed to, and requiring either security or even our police officers to be involved. So tremendous advocacy from our residents and frontline nurses and others to push the leadership into making the changes that have now given rise to the pilot that Jamie Phillips described. And really kudos to her and the team that she works with for taking this on, recognizing the urgency of the issue, getting full support from Sheila Antrim and others to do this work. And I've just been incredibly excited to watch it as it progresses. Again, appreciate everyone joining today. I think we'll bring this to a close. I will thank the leadership of Vice Chancellor Navarro and President and CEO Mark Larrett of the health system for their leadership in this important space. You've heard mentioned several times today the important new coursework in the Foundations for Diversity, Equity, and Inclusion, that training module that was released last November, and that it is my expectation that every single member of the UCSF community will undergo that training so that we can all have a common language and a common understanding of the journey ahead. This series will continue, and I invite all of you to join the next session, which will be held on May 19th. That is the Chancellor's Leadership Forum on Diversity, Equity, and Inclusion, where, again, Vice Chancellor Navarro and I, with other members of the UCSF community, will review ongoing progress and challenges that we are making on a wide variety of DEI issues. So thank you for joining us today, and I hope you enjoy the rest of the afternoon. Thank you.
Thank you.